Well, good morning, everyone. Those here in the room with us and those online. I'm Judy Nichols, President of Association of Lifelong Learners, and we welcome you to today's program, which is certainly a timely program. If you watch TV at all, you will see a variety of ads about Norcon and people in need of it, and also news reports on the addiction, the crisis here in northern Michigan. So we're pleased to welcome David Mcgreaham, MD, who is spearheading this opioid program now and traveling around and sharing messages of impact on our community and what we might be able to do to help out. So welcome. We're glad to have you here with us today.
Thank you. Great. Again, thank you for the introduction, Judy. My name is Dave Mcgreaham. I'm a physician. I practiced in Traverse City and then worked in hospital administration for about 15 years as a chief medical officer. And after I retired, I unretired and started working for an organization called the Northern Michigan Opioid Response Consortium. Next slide. We cover about 21 counties in Northern Michigan. We work under a federal grant through Health and Human Services. There are a variety of organizations like us throughout the country. We have about 35 member organizations. Next slide. Our mission is to engage Northern Michigan in a coordinated response regarding substance use disorders. And what we're finding and what all organizations find, there are a lot of folks out there doing great work. We don't take credit for most of that work, but we do help to get folks together to talk about things and to share resources and ideas. Next slide. We started actually in 16 counties in Northern Michigan, including Alpena County, about 3 years ago. And you're good. And under the grant that we operate under, we focus on prevention, treatment, recovery, and workforce issues regarding initially opiate use disorder, but it's expanded to substance use disorder in general. And I wanted to touch, next slide, touch on some highlights of the work that we're doing today and talk about substance use disorder, how we got here, and some solutions to where we might be going with this problem that we're working on. Next slide. So I think most of you probably know who this is. Anybody? Okay, next slide. This is Janis Joplin. And she died at age 27 of a heroin overdose. And the reason I'm showing Janis Joplin is heroin's been around for a long time. This isn't a new problem. It's kind of waxed and waned over the decades. But she was 27. She had recorded her Pearl album in October of '79. It was released in February, and me and Bobby McGee and some other hits came out at that time posthumously. Next slide. Another famous person died at age 28 of a bunch of medications that interacted. And that's often what we see. We're seeing people that are dying of typically not just one medication, but multiple medications in their system. Do any of you know anybody that's overdosed or? Okay. The thing that I'm finding, that we're finding when we talk to people, this has touched a lot of people personally. This isn't something that, happens to somebody you don't know. It often happens to somebody you know. It can happen to a sibling, a parent, a cousin, a neighbor, a friend. So this is very real for a lot of people. And I'm showing some celebrities, but there's folks out there all over that are suffering from substance use disorder. Next slide. Just to put this in perspective, I'll talk about substance use disorder, which encompasses a lot of things. And then there's opiate use disorder, which is a subset of that. 2 million people are living with opiate use disorder. 1 in 8 of us will develop some type of substance use disorder in our lifetime. That's a lot of folks. Addiction, and I'll use the term substance use disorder and addiction interchangeably. But basically, addiction is a treatable chronic medical disease like any other chronic medical disease. Folks respond to standard treatments and do as well as others with chronic medical diseases. Next slide. So just to put it in perspective, when I'm talking about substances, the biggest substance that people struggle with is alcohol. And this isn't, this is past month substance use disorder. This isn't the number of people that are addicted. This is the number of people that have used these substances. But alcohol use disorder is one of our biggest challenges. You can see tobacco. Again, a huge challenge. Nicotine is one of the most addictive substances out there. And then we have a variety of others here. I'll talk mostly about heroin and some of the other opiates and touch on methamphetamine as well. Next slide. Do you guys want to ask questions? I mean, I'm open to questions as we're going along, so feel free to interject anytime you want to. So let's talk a little bit about opiates. Opiates have been around for centuries, derived from opium poppy, or from poppy seeds, basically, and opium. They're natural compounds. Codeine and morphine were some of the original opiates out there. Then we started developing other substances, and we have heroin, oxycodone, some others that we call semi-synthetic. They take basically poppy seeds in the extracts, and they do some things chemically to them to make these other compounds. And then we have totally synthetic opioids, as listed here, some of the examples, one including methadone, another fentanyl, and those are made in labs. Next slide. What happened in the 80s and 90s, pharmaceutical companies started synthesizing pain relievers. And I think most of you know this history. They were touted as not being addictive, and then marketed for the general public and the physicians. And we saw this huge surge in prescription opiates. And you can see that we peaked out probably 2010 to 2012. Next slide.
What was it that they were creating?
Oxycodone, like OxyContin, Percocet, a variety of other medications. Fentanyl came along. So these were touted as pain relievers, and the marketers said that they were not addictive. The physicians basically bought in, and it wasn't until well after the fact that we started seeing that people do get addicted to these medicines. And then publicly, pain was felt to be something that no one should put up with. So if you had pain, you should be treated. You shouldn't have to put up with pain. And in higher and higher doses, people were being treated by physicians and other providers. I think you're all aware now, Purdue and Big Pharma, there are settlements out there because this really was found not to be true. These are, hi.
You didn't tell us you were going to be in person.
Hi,
I
Tom.
got my suit clothes on.
Tom's a distant cousin of mine. Thanks for coming.
We were watching on Zoom. I said, we can go get autographs.
Yeah, talk to me later.
Some days we have no control over the crowd.
As yeah, Tom's one of those folks, I know. So anyway, so if you look at opiate prescribing practices, dark is bad. And all over the country, you can see these dark swaths. And a lot of these were rural counties. And you can see Northern Michigan has had its own issues with opiate prescribing. Alpena County had a very high prescribing rate. The good news is the prescribing rate has gone down dramatically. The bad news is when you start tightening up prescription opioids, a lot of people migrate to heroin and fentanyl. So you almost create another problem or add to that problem. Next slide. Some of you have probably seen this. This is a plot of the overdose deaths from 99 to 2018. And the synthetic opioids, that's basically fentanyl. We're seeing a spike there. Heroin has kind of leveled off. These are prescription pills, basically. And they've kind of leveled off and gone down. But again, this huge increase in fentanyl overdoses and deaths. And there's another line that I didn't put in here that would end up about here, and that's methamphetamine. We're seeing, fentanyl come down a little bit. In some respects, meth is going up, but we're also seeing meth laced with fentanyl and cocaine laced with fentanyl. So, and even pills, manufactured pills, illicit pills are being laced with fentanyl. So it's out there, it's dangerous. Next slide. And then a lot of you saw this headline. This was from July 2020. We had a really bad year. We think it's because of COVID, isolation, stress. People started using more illicit substances, and there was about a 30% increase in overdose deaths, up to 93,000. And that trend has maybe come down a little bit this year, but it's still much higher than it was a couple of years ago. Next slide. So let's talk about the definition of addiction a little bit. And I touched on this, but addiction is a chronic disease. It's typically relapsing. What happens when you use these substances, they rewire your brain so that your brain becomes dependent on the substance to feel pleasure, and your brain becomes short-circuited. Your thought processes change, your rational thinking changes, a lot of things happen, so that we're looking at this as a brain disease. A lot of other chronic diseases out there, high blood pressure, diabetes, obesity, and we're looking at treating this disease just like any other chronic disease. Next slide. So just to touch on the brain just for a moment, doctors really like doing this stuff, but so this is your midbrain. This is your cerebellum. So your reward centers kind of come right from your midbrain up to this area, and then up into your frontal lobes, where your judgment, your memory, your day-to-day function can be impacted. When you take these substances, let's just talk about opioids. There's a part of your brain that kicks out this substance called dopamine in the pleasure center, and a lot of you probably heard about this, kind of in this area, and then that shoots up to your frontal lobes. And again, unless you have that kick from the substance, you just don't feel right. And what's interesting with addiction is people go from feeling high and feeling pleasure to just not wanting to feel sick. So there's this spectrum of addiction. Again, a lot of folks that are taking substances, they want their next dose so they don't get sick. Next slide. So substance use disorder, it's not just about the drug itself. There's a lot of things that go into the development of substance use disorder. There's a genetic component, and there's a big overlay with chronic mental health illnesses like depression and anxiety. Those folks tend to have more of a predilection towards substance use disorder. If you're not exposed to certain drugs or alcohol, you're probably not going to develop substance use disorder, but we're seeing more and more exposure in teens to a lot of different substances. I mean, vaping, nicotine, the teenage brain is very susceptible to becoming addicted. The brain mechanisms themselves that I touched on, and the environment. Next slide. Just a couple of things. People with family problems, people with adverse childhood events or trauma in their childhood are often more prone to chronic diseases, not just addiction, but other chronic diseases as well. But we see a lot of folks, and we see families, multiple generations, where there is abuse or trauma, and the drug abuse, the drug use is very high in those families. And mentioned early physical or sexual abuse. Until you get folks talking sometimes about those childhood issues, it's really hard to treat their substance use disorder. Next slide. So treating. a lot of components of treatment. It's not just one approach, it's a lot of different approaches. And some people, and let's just talk about alcohol use disorder. Some people have to go into a detox unit. They have to be withdrawn from their alcohol or from their opiate or whatever substance they're taking. Not everybody has to go into detox. Some people can be treated as outpatients, but they need a variety of things. I mentioned counseling. That's typically a psychologist or a social worker or a psychiatrist. I mentioned recovery coaches here. And do any of you know what a recovery coach is? A recovery coach is somebody that has had substance use disorder and was treated successfully. So they have not used any illicit substances typically for a period of a year or two. They go through training and they're basically your coach. But they're more than that. They know the game. They know how to play the game. So they're very helpful with people that have substance use disorder. Support groups, you've heard of Alcoholics Anonymous, Narcotics Anonymous. These can be very helpful in people with substance use disorder in talking with other folks that have it and keeping each other accountable. Support from family or friends. And I mentioned sometimes you have to leave your family or friends. What treatment sometimes does is it gets you out of that environment. You go right back into it. Your chances often go down with successful treatment. Social support. If you don't have stable housing and if you don't have a job, it's really hard. Folks that are suffering from homelessness, really hard to get them treated successfully in the long term because housing is probably one of the most critical factors in stress in your lives. And medications. What the medications do is they help with the craving for the drug, and they make people come out of the social environment where they were seeking drugs. They get out of that environment. It helps the brain to heal. It often takes a year or two, but we'll often see improvement within a month if people are taking some of these medications. And it basically prevents them from overdosing. And if you look at some of the medications that we're using to treat substance use disorder, what we see is people don't die anymore. Next slide. So you may or may not have heard of some of these medications. I think a lot of you have heard of methadone. Methadone's been around for a long time. Methadone really is a substitute for medications or heroin or fentanyl. You're taking that drug and you're giving patients methadone, and it really uses the same receptors in their brain. So it's a substitute. Did you have a question, Lisa?
Do we know if there's any effects when a pregnant mother is taking methadone by the doctor and when needing methadone at first? Are there any effects on the
They can suffer a withdrawal syndrome, but it's usually, those folks are usually monitored in a high-risk center. And my understanding is a lot of those moms switch to buprenorphine or Suboxone, where you don't get the withdrawal symptoms. So there's a way to do this to manage the withdrawal. The biggest cause of neonatal abstinence syndrome is nicotine. It's moms that are smoking. Nicotine, cigarettes are the biggest cause of, it's called neonatal abstinence syndrome, where the baby goes through withdrawal. They're very irritable, typically for like 3 to 5 days, because they're going through withdrawal. Nicotine's the #1 reason for that. So buprenorphine binds to the opiate receptors. This fully binds methadone. Buprenorphine partially binds and blocks any other medications. If you use heroin, buprenorphine blocks the effect of heroin, so you can't get high. But it also mimics opiates to the extent that the patient taking buprenorphine doesn't go through any kind of withdrawal, doesn't feel any craving, but again, is safe from overdosing. And then naltrexone or Vivitrol is a complete blocker of the opioid receptor. The hard thing about naltrexone, Vivitrol, is you have to be off of your opiates for 5 to 7 days before you can start it. And the advantage of buprenorphine is you can start it anywhere, almost any time. You have to be going through mild withdrawal, which is usually a day or two after you're done taking whatever you're using, but you can start it very quickly. Next slide. And so where do you start buprenorphine? Wherever you can, wherever you have a willing patient and a willing provider. You can start it in your provider's office. And in Alcona Health has, I think, 300 patients on buprenorphine. Emergency room physicians can start this. It's not happening in Alpena, but there are several around northern Michigan where they're starting it right in the ER and then having the patient follow up with a provider in a day or two. Jails. We are hoping that more jails will use buprenorphine, but a lot of the jails now are only comfortable with Vivitrol, which has some danger when folks are released from jail. There tends to be a higher overdose as people maybe taper off their Vivitrol. Mobile vans, there's one in Cadillac where they have a provider that is there a half day a week. And they're seeing folks that need buprenorphine, and that physician is starting it right from the van. That's his office. There's another mobile van that comes out of Saginaw. Dr. Bill Maroney sends it to 4 or 5 cities in the southern tier of this region. Telemedicine, you can start buprenorphine via telemedicine. You can start it at home. The first dose is, it's a little tricky, but not really dangerous. And I mentioned here, induction is that first dose. And a lot of providers are a little bit skittish about giving that first dose until they've had some experience. But it's a standard protocol, and patients take it, you put it under your tongue. It's not swallowed, it's not injected, it dissolves under your tongue, and you kind of go from there. You figure out what dose the person needs to maintain them. Next slide. So if you look at buprenorphine providers, actually Alpena County, you guys are doing okay. And again, it's because of Alcona Health. I don't think there are any practitioners in town other than Alcona Health that are prescribing buprenorphine, but they're taking care of a bunch of people from around the region. Traverse City, there's some providers, but we got this big swath right down the middle of our region where there's really no providers prescribing buprenorphine, which is something we're trying to work on. Next slide. So why not have all the doctors prescribe buprenorphine? There are a lot of doctors that are reluctant to do this. There are a lot of doctors and their staffs that do not like working with folks with substance use disorder. They don't want them in their offices. They can be tough patients. They can be challenging. They need a lot of resources. But the practices themselves can have a stigma in the offices. It does require some extra training. It's called a waiver training. It's an 8-hour training course that doctors have to take. If you're a PA or nurse practitioner, it's 16 hours. A lot of practices just don't have the setup to do this. A lot of practices don't have supportive partners. So there's a lot of barriers out there to using buprenorphine. And then again, I mentioned this can be complicated to do if you have somebody that's unemployed, if you have somebody that's struggling with stable housing, they need a case manager to help them out. And then behavioral health and recovery coaches, we just don't have enough. So you can just use buprenorphine and treat somebody, but your best outcomes are going to be if that person's seeing, say, a social worker for counseling and having a recovery coach work with them as well. So again, it's a multifaceted approach. Yes.
What's the influence of insurance or reimbursement payment to the physicians for these kinds of patients? Is that an issue?
The barrier is probably more the paperwork. Insurance coverage is reasonable. These medications are typically, the medications themselves are also covered by insurance. Case management may or may not be covered. But it's like a lot of other things. You've got to do it probably the more you do, the better you're at it. But yes, there are insurance barriers. Medicaid actually covers this pretty well. If you go to a place like Alcona Health, they're a federally qualified clinic. They get extra funds for case managers and social workers and others. They sort of have one-stop shopping there where you can get your medications, you can see a social worker, you can see a recovery coach all on site. And if need be, some places have telemedicine access to behavioral health. That can be helpful as well. Next slide. So let's go back to those overdoses, and the details on this aren't that important, but this is 2019. These were overdoses seen in emergency rooms around Michigan. This is 2020 when it popped up during COVID. It's continuing to remain higher than 2019, but it came down a little bit for a few months. But basically, we're dealing with this surge in overdoses nationally and in the state of Michigan as well. Next slide. So what are we doing? And I talked about the treatment of substance use disorder, but I want to also talk about saving lives more on the front end. And I think most of you know what Narcan is or have heard of Narcan. It's a drug that blocks those opiate receptors. And if you've overdosed, the opiate receptors in your deep brain basically cause you to stop breathing. And what Narcan does or naloxone does is it binds to those receptors, pops the opiate off, and lets you start breathing again and lets you wake up. So there's a lot of organizations doing a lot of really good work out there with naloxone. And I just want to mention harm reduction and health departments. They're often going right to the folks that are using illicit substances. So they're going to homeless shelters. They're going to other places. They're doing the mobile vans. 80% of the saves that we see with Narcan are from people that are using with other people and have Narcan available. Okay, so that's 80%. So this other stuff is kind of the 20% that we can help with. And a lot of those saves are by EMS and police, frankly. So the general public, those of us in the room can still help, but the numbers are much smaller. But I want to mention a couple of programs that I think are really neat out there. The first is called the Emergency Medical Services Naloxone Leave Behind program. That's where if an ambulance is called to an overdose site and they resuscitate you and you're okay, they can leave naloxone at your home. With you, with your family, with your friends, with bystanders, they can leave it with anybody that's interested in having naloxone. So that's a fairly new program. It's implemented in about half the EMS programs around the state, not yet implemented in Alpena. Emergency rooms. If you go into the emergency room and you suffered an overdose and you wake up and you're deemed to be stable, they'll send you home with naloxone. So that's another thing that Alpena is doing that. I think most of the hospitals now in Northern Michigan have that program where they'll send you home with naloxone or your family members home with naloxone. A lot of those folks, a lot of folks are admitted, frankly. So the numbers that come in and leave are not as big as you'd think, but this program is available. Yes.
Not long ago, the Sunrise Center- Not long ago, the Sunrise Center here had an afternoon where they gave away the, how do you pronounce it, naloxone. But I was wondering if a mom has teenagers at home and maybe they aren't necessarily using these drugs, but maybe marijuana or something, would it be advisable for that mother or father to have those in their home just as a prevention?
I don't see a downside to it.
Oh, okay.
I think naloxone is like having a first aid kit.
Mhm. Yes.
I've got it in my car. A lot of people keep it in their car. It's probably good for 2 years in a car because of the heat and the cold.
Mhm.
But if you happen upon a scene where somebody's overdosed,
Yes.
the more people that have naloxone, the better.
Mhm.
It's very safe. There's no downside to using it.
Mhm.
People always think that you're going to find somebody That's an obvious addict that's down from an opioid overdose. It could be you. We have a lot of folks 65 and over that are on opiates. And it's not just the obvious addicts that need naloxone. Sometimes it's in your own home. And I talk a little bit about pharmacies in here, but if you're taking a high dose of pain pills, prescription pain pills, you should have naloxone at home as well. So in fact, I've got some handouts for folks that might want to order it.
And then if a person really had an overdose, but they were passed out and someone gave it to them, would it hurt them?
No,
Oh, okay.
there's no downside. It's really a harmless medication. If yeah, there's no downside to using it.
Well, thank you.
You bet. So I mentioned jails. A lot of the jails in the area are now sending folks home with naloxone because that population has a high incidence of substance use disorder. We would love to see the use of Suboxone or buprenorphine in the jails. They are using Vivitrol in a lot of the jails. Again, sending folks home with naloxone seems very prudent because that population tends to be using illicit medications, or they were incarcerated for the use of illicit medications. Opioid overdose kits or naloxone overdose kits or naloxone safety kits. Next slide. Oh, let me touch on this first. So part of my job has been to go to a variety of pharmacies around northern Michigan, and I started asking if they're giving out naloxone. They have standing orders through the state of Michigan. If you're on a high dose of opiates, prescription opiates, they can just say, Tom, you should have naloxone at home. And your insurance will cover it. There might be a copay, or there is a copay, but if you're on Medicaid, it's $1. If you're Blue Cross, it's $5. If you're on Medicare, it's $50. So what the pharmacists were seeing is that they would offer it to people, and they'd say, I don't have $50 to pay I can't afford the $50. So what we did is we came up with this handout that we've been giving to a variety of the pharmacies in the region. We partnered with Rite Aid throughout the region. Corporate Rite Aid was very interested in this. But this is a series of online resources. You can go online, go to these sites. Next Distro is out of the state of New York, but has affiliations in Grand Rapids as well. Families Against Narcotics, and then Harm Reduction Michigan. You go online, you watch a 2-minute video, they send it right to your home. No copay, no questions asked. I think you can get 2 or 3 kits, and you can order it for your friends or whoever wants it. And again, it's a real easy way to get that medication into your home, especially if you have a high copay or if you just want it sent directly to your home. Harm Reduction Michigan has a neat approach. You can call them or text them, and they will send it right to your home. So some folks do not have access to a computer or aren't that computer savvy to get online and do this, so they can just text Harm Reduction Michigan and get it sent to their homes. Next slide. So we got a grant for these safety kits, and these have been pretty well received. This is one of the regional libraries where they have an AED, an automatic defibrillator, and they mounted a naloxone safety kit right above it. They had an overdose in this library, and they wanted naloxone available. So they trained their staff on how to use it. This is very visible and easy to get at. We got a grant to start disseminating these kits. And next slide. So basically it's this red box. And I'll just pass it around. Has naloxone inside. Next slide. It also has a small mask inside. Yeah, you just have to figure out how to open it out. This is a defibrillator in a medical clinic. And I talked to the folks. This is near a substance use disorder clinic. The SUD clinic was on the next floor. This is on the first floor. in a healthcare facility. We're going to just stick a red box right in with a defibrillator. When you open that defibrillator, the alarm sounds for the hospital. Somebody comes to help, but they thought it made sense to have one of these safety kits right on the ground floor in this, because the first responder may not be somebody from the hospital. It might be the friend of the person that overdosed. And if we have this handy, we think the more we have out there, the merrier, frankly. Next slide. So we've had these put in about 20 regional libraries and about 20 community type centers, churches that have recovery meetings, counseling centers. We've got a goodwill center next. And I had met Judy at the Hillman Chamber of Commerce, where we did this presentation, and subsequent to that presentation, we were contacted by the Hillman schools, and we put the full safety kit mounted in they have a junior high school, so it's mounted there. And then in their elementary school, they just took a red box because they have a first aid kit and a resource person on site. So they've got a red box, and the high school has the whole kit. One of the people on the Hillman, he wasn't at the meeting, but he's part of the Chamber of Commerce. He owns and runs Thunder Bay Resort. He heard about this and actually helped get it into the schools. He wanted one for his lobby at the resort and also for his employee lounge, because he said, I know I've got folks here that have substance use disorder. So if somebody goes out, we want to help them. So we got 2 to Thunder Bay Resort. The Shoreline Church here and the Bayview Drop-In Center in Alpena also have the entire kit. So next slide. So just some other innovative things going on. Wayne State, there's, what is it? Center for Behavioral Health and Justice got a grant to refurbish vending machines. And they're trying to disseminate these to different areas of the state. They have them in several jails. The Alpena Aleno Club has one of these. Baldwin has one, and the Cadillac Jail just put one in. Again, inmates, this is great for family members or inmates that are leaving. But basically, these are free. You just, pull on the button or press the button, and you get a free naloxone kit. And I think that's a great way to get it out. I personally think in the jails, there should be a conversation and somebody ought to be giving it out. But I think some of the jails are so busy, they don't really want to deal with that process, but they're okay having a vending machine there. The Cadillac Jail got some bad press over this, where people came around and there were some letters to one of the periodicals that said you're promoting addiction. And that's one of the things that we struggle with, is people look at naloxone and say, all you're doing is making it safe for those addicts to shoot up. And what we're trying to do is save lives. The thing about harm reduction, and this is called harm reduction, it's really being non-judgmental. I don't care why you're using fentanyl or heroin. I wish you didn't, but I don't want you to die. So take this, please, and resuscitate your friend, have your friend resuscitate you, do whatever you need to do to stay alive, because maybe in a year or two, maybe in a week, we'll get you into treatment. And a lot of the folks that have been resuscitated from overdoses end up being back in the workforce, and they're living healthy and productive lives. But they go through that stage with their substance use disorder where they need to be resuscitated. Next slide. So some other, this is a lock bag. And we got a bunch of these also. These are for folks that have prescription medications that may have children or grandchildren where they don't want them to get at it. Each of these has its own distinct key. So we've been giving these out for free also. Next slide. This is a disposal bag. This has activated charcoal in it. You can put up to 45 pills in here if you've got narcotics that you need to get rid of. You can typically bring those to a police station or to your local hospital, but some people just would rather get rid of them at home. So you basically fill this with water and throw it in the garbage. It destroys the pills completely. Next slide. So let's go to the next level of harm reduction, and that's syringe safety programs. And this is where it gets tricky because people really think you're promoting addiction. Syringe safety programs are programs where you go, if you're using fentanyl or heroin or meth and injecting yourself, you can go get clean needles. And what happens is the incidence of hepatitis C goes down dramatically. Hepatitis C is very contagious. People that are injecting substances are often sharing needles. Their needles are old, they're dull. They can get hepatitis C, hepatitis B, HIV. They can also get abscesses and other infections. So there are organizations like Harm Reduction Michigan and some of the health departments that are giving out syringes, no questions asked. They'll take your old syringes, give you a new syringe or new syringes. They're clean. They're trying to, again, prevent infections. Hepatitis C over the course of a lifetime and HIV each cost about $100 grand to treat. So if we can prevent these infections, it's a good thing. Hepatitis C is very contagious. If I had it and rubbed my nose and touched that podium, hepatitis C would be on there for 2 days. It's extremely contagious and it lives for a long time, whereas HIV, hepatitis B, most of the viruses are dead in a couple of hours or shorter, but hepatitis C hangs around for a long time. So very important, but this is where people's biases really come out. They just can't wrap their heads around this, and that's okay. We're making some progress, but we got a ways to go. Next. So some of the other things going on in Alpena, again, I mentioned Alcona Health. We work with the medical center here as well. These other entities are part of our organization. There is a recovery house in Alpena that will take 5 women, is my understanding. But recovery housing is very important. People that have gone through detox or need to get out of their environment, if they can have stable housing, that's very important. There is a Families Against Narcotics organization here. I think it involves 2 or 3 counties. They meet, I believe, once a month. Michigan State Police have what's called their Angels program. I think a lot of you probably heard about that. You can walk to a Michigan State Police post, and some of the city police departments do this as well. You can basically go and say, you know, I'm using fentanyl. I want to get into treatment, and they will call resources, try to get a referral to a treatment center, and they will arrange transportation for that person to go to a treatment center. Most of the treatment centers are downstate. So a lot of times, logistically, it's hard to get people there, but this program, folks have signed up to help. They've gone through training and they'll give the person a ride. Typically, there's a police officer with what's called an angel. That's the person that's interested in substance use disorder that's going to help with the driving and get folks to where they need to be. The naloxone safety kits I mentioned, and we've gone through that. If any of you are interested in learning more about our organization, I've got some cards up here, and we're always looking for folks to help. If you know of any place that would benefit from these kits, let me know. Because again, I think these are for the public to see and for the people using the substances to see. The other thing about these kits is they often start a conversation. Several of the libraries that we got into, we had to talk to the library boards, and you kind of get back to that stigma discussion. And when there's a library board talking among themselves, about the benefits of naloxone. Sometimes that stigma kind of gets aired out. So the benefit is not just in having it available for folks that overdose. I think the benefit is for the public to see that, this is good for the community. And for some of those biases to come out to be discussed. So if you have places that would benefit from these, let me know. Any questions? I think I've probably gone over a bit, but.
Anyone? Excuse me, your microphone so that those online can hear.
Sure. Have you or do you know of any conversations about kind of moving this from like a law enforcement or a criminal justice issue to more of like a public health crisis and kind of empowering medical experts and social workers to treat this?
Yeah, I started back in Traverse City 6 years ago, where one of the judges, he was a prosecuting attorney at the time. He said, I can't prosecute people out of this problem. Prosecuting attorneys, courts are starting to realize these folks need to go into treatment. They don't need to go to jail. So there are what's called recovery courts, where people with this violation go to regular court, and the folks with substance use disorder go to another court. A lot of those folks are alcohol use disorder. It's drunk driving. That's probably the majority of them, but there are others, that are using illicit substances that get into treatment through the court system. The police, similarly, I think 10 years ago when there was an overdose, they called the cops because it was a crime, right? So the police wanted to be there. Well, the police now don't necessarily want to be there. They want EMS to be there. It's like somebody's overdosed. We'll figure out if there was a crime committed, but save their life, get them into treatment. So I think a lot of the police and a lot of the court systems have started evolving. I mentioned jails. I think it's very dependent on the jail. And the jail sometimes depends on the sheriff and the county commission. And we have some sheriffs that are very supportive of the treatment of substance use disorder, and others that see it as a crime. So I think we're trying to move those folks along and making some progress, but again, we have a ways to go. But in general, I think law enforcement supports, let's treat it like a disease. Let's get these folks into treatment. And interestingly, if somebody goes to jail and is released with a substance use disorder and has been treated, they end up back in jail. So it's just this circular thing. Whereas if you get them into treatment, they still may end up back in jail, but the percentages go down and the jails do better overall. So the more treatment we can get into jails, the better.
Yes, I'm on a board of education, and I want to bring this up. And we do have, what'd you say? Naloxone at our high school.
Good.
And also, we just built a new jail on M32 as you're coming in, and we toured it, and the sheriff was conducted the tour, and he said, I don't know if it's 80% of his inmates are in there for like meth.
Yeah.
And he said he does not have the expertise to, to do anything besides incarcerate these people,
Right.
And then
I think
and all that Lisa tell you.
and isn't the library
she
new
is in.
here? Didn't you guys just build a library too?
Yes. Just
Yeah, I think, and we'd approached the library. I think they said circle back when we're done building it. And I think with the jail, yeah, people are so busy, but I'll make it a point to have one of our folks circle back. Catholic Human Services has been very active. They're an organization that works through the Medicaid provider, the state Medicaid provider. They've been in a lot of the jails. And actually in the county south of here, I didn't mention this with Narcan, they have recovery coaches. If you have overdosed or think somebody's at risk for an overdose, they'll go to your house and they'll knock on your door. It's usually a recovery coach with a social worker, maybe a police officer out of uniform. But basically they're there to try to get you into recovery, provide you resources, give you free naloxone. That's a real innovative program that's been taking off. So.
And I believe our sheriff is, he's open to this because he's a repeat offenders, and he is only, and they're sentenced to jail, and that's what he has to do, but he knows he's not really helping him.
Right. The hard thing about meth, people that use meth, it's often laced with fentanyl, so they ought to have naloxone. The treatment of meth addiction is very, very limited. You go through withdrawal, and there are some medicines to help with withdrawal, but there's not a Suboxone. There's not an equivalent medication for meth. And it's counseling, it's therapy, but meth is kind of a different beast. Very addictive. And folks on meth have more of a tendency towards meanness and violence and psychosis. So a meth addict can be different than a heroin addict. And so many of the overdoses now are meth. So much of the substance use is meth. That's a real challenge. But
You have a family member you know that's doing meth. What can you do?
I think
She won't get into,
I could give you a number for these. They're called wellness response teams. They can give you advice. You could call Catholic Human Services. You could go to Narcotics Anonymous. Or go to a FAN meeting. Actually, FAN is probably a really good resource because a lot of the families there are struggling with a child that's struggling with substance use disorder. And the FAN meetings often have resources and folks talking to each other about how they would handle that.
Person who has been on meth, are there long-term side effects from that, even if they get clean?
Depends how long they've been on it. What we're finding is that long-term use of meth is inducing a Parkinson's syndrome. Okay, so long-term meth use depletes these transmitters in certain parts of your brain, so they will have a tremor, and their memory may not be as good, their thinking may not be as good. So yes, there are, even if you get off of meth, if you've been on it for a long time, it
And what
can
about
cause permanent
mental
damage.
health issues from it? Does it change your brain?
It does.
Yeah, okay.
Yeah. And again, I think the difference between meth and heroin and fentanyl, I think people using meth tend to get psychotic. They tend to totally lose it,
Okay.
lose touch with reality. And I think they're harder to deal with from a behavior and an anger standpoint. So it's kind of a different beast. It's important to remember is these brains change, but they can change back again. And part of that change is this irrational behavior. They don't process. It's like, why would you do that? Well, their brain's not normal anymore. So they're not processing like a rational person. That's part of the disease. And even in treatment, it's really hard for a couple months until that brain starts healing for people to commit to treatment, to be rational, to start their thought processes over, because their brain's different. So a lot of that behavior, again, is part of the disease. Where it gets really tricky is the criminal behavior. Because over time, people with substance use disorder sometimes will steal, sometimes will deal drugs. They'll do whatever they can to get the medication. So you have to get them off the medication, but there's a subset that are still criminals. So that's where it gets really tricky to sort it out. But you have to give folks the benefit of the doubt that criminal behavior is part of the disease as well.
Yeah, well, we thank you very much for being here and for sharing this information. I can't say it's good news.
Thanks for
but,
having me. Well, I think the good news is we're making some progress. I think as communities, I think the bad news is we got a lot of overdose deaths and a lot of people out there hurting. So,
But perhaps each of us can reach out to other entities that might benefit from a presentation like this, or from using the red box or whatever, and maybe being aware, talking about it will indeed help.
right, we're happy. I'm part of a team of 2 that's going to 4 because we had lost a few folks, but we're happy to do community presentations and tailor it to whatever folks want to hear about.